I'd like to go ahead and introduce our next presenter segment. Dr. Jennifer Hartley is Medical Director of Withdrawal Management for Fora Health Treatment and Recovery. She's a family physician and addiction specialist with interests in complex withdrawal management, patient education, and customizing care that meets each individual's needs in the context of their unique life story. I think we're going to have our minds blown with a lot of really amazing information coming up here. So please join me in welcoming Dr. Hartley. Jennifer, it's all you.
Thanks, Paul. And thanks so much, Amanda. It was a delight to listen to your presentation. Amanda was one of my teachers in fellowship, so I learned from the best. I'm really, really happy to be here today and share with you some of what I have learned in the last couple of years, really in the trenches, treating people as they withdraw from fentanyl. We started seeing here at Fora, which we used to be DePaul treatment centers in downtown Portland, and we were still DePaul at the time that fentanyl really hit us. And we just saw, as we all saw collectively in whatever setting we practice, right, that the old ways of doing things, the ways that we managed heroin withdrawal and withdrawal from prescription opioid pain medications just weren't working. And patients were not successfully getting onto buprenorphine, and all kinds of terrible things were happening. So what I'm going to share with you today really is what I hope will be just some very practical tools to help make this less frightening in whatever role in the process you may have. So less frightening for you and less frightening for patients. So with no further ado, also, I just wanted to say at the beginning, I do have that reference on the monoproduct commentary at the end of this slide deck. And I have just two references at the end of the slides because there are a whole lot of references I could have put in for this presentation, but I wanted to kind of give the ones that people really wanted. So if you can pop into the chat, you know, if I talk about something and you're particularly interested in a reference on it, I'm sure I have it, and I can get those to Stacie so they'll be available. Okay. Okay, so learning objectives, just really to understand what are the challenges, and what are the transition options available? What's the menu? What are the range of strategies that you can use, and how to help your patients think through in whatever setting they're doing this, what is going to be the best approach for each individual patient? And then again, what are some tools to help your patients through this process successfully and also comfortably? So deep breath break here at the beginning for all of us, just to acknowledge that this process can feel overwhelming. It's definitely challenging, and it's possible. We're doing this every day, even for people who have really high use patterns. So just to recap again, what are the challenges, right? Well, fentanyl, as Amanda has outlined in detail, it's really strong. It's lipophilic, it's stored in the body, and it has this process of kind of coming out slowly, which makes transitioning to buprenorphine so hard. Patients experience the withdrawal starting sooner, so a lot sooner. They get really uncomfortable really fast, they can. But precipitated withdrawal can occur much further out from last use when compared with heroin withdrawal, up to days out, actually. The withdrawal picture also looks really different than heroin withdrawal. It certainly shares a lot of features with other opiate withdrawal, but it has its own unique characteristics. In particular, this very, very severe restlessness picture, and also very severe anxiety. And that anxiety can last after successful transition onto buprenorphine, which Amanda also mentioned. And I think those are really two of the most difficult challenges we face. And then on top of that, there is this kind of global fear stemming from the really not successful experiences a lot of our patients have had trying to transition to buprenorphine. And there can be this belief that I just can't do this. This isn't possible, but it is possible. Things that have changed in the way that we manage the technical pieces of starting buprenorphine. The cows, which used to be very reliable for measuring when a person was ready for their first dose of buprenorphine, is a bit less reliable. It's possible for patients to hit a pretty high cow score and still not be ready to be inducted. And it's really important not only to look at the total cow score, but to make sure that the patient has at least 2 objective signs, I would say that 3 or better, of opiate withdrawal before you do the induction. Another thing that I've really learned here the hard way is that the traditional 4 milligram induction doses that all of us who did the waiver training learned, this is the way you start buprenorphine, they really don't work very well. And in my experience, they're enough to precipitate withdrawal pretty badly. And then it's really hard to get through that withdrawal and get out of it with 4 milligram doses. What we've learned and colleagues around the country have learned is that higher induction doses are much more effective. And then as Amanda spoke eloquently too, we see that doses higher than 24 milligrams are commonly necessary. These are just some quotes from patients about what this withdrawal experience can feel like. I hear this over and over and over again. And just to kind of describe my setting, I admit to Fora 6 days a week. I spend a lot of time in our dorms sitting with patients on their bed. So like really sitting with patients as they go through this experience. I make the analogy again and again. I'm a family doctor. I used to do a lot of obstetrics, and there's so much about fentanyl withdrawal that reminds me of labor. So I really have been fortunate to just hear that kind of in the moment descriptions from patients of what they're feeling, which then is so helpful to know what really needs management and what specifically they need to feel better. So I thought these quotes really just spoke to some of the most common things that we see, which is this horrible restlessness and kind of skin crawling. And patients will say, I can't be in my skin. I have to get out of my skin. And then this very low back pain that we see. I haven't mentioned that yet, but this is another thing that I have found that's really unique to fentanyl withdrawal. You can see it in all ages. It's a bit more common just anecdotally in our practice here and people who are on the older end of the age spectrum. And one gentleman described it as, I just feel like that the dope is coming out of my back. The fentanyl's coming out of my back. And then again, this intense anxiety after the maintenance dose of bup has been achieved. And patients will just say, isn't there anything that can make me feel less anxious? So in the face of all of this, it's so important to have a clear game plan in your mind. We find here that it is just so, you can sort of just see patients come in the morning. We had met from the sidewalk early in the morning, and people come in all kinds of emotional states. And when they come into the exam room, they're often just so scared. And you can really just kind of see that their temperature of their fear go down when they know that the provider and the rest of the staff here has done this and has a clear plan and is confident that we can help and that we're going to take good care of them. So the first piece of this is to really know your patient, and we're so rushed in medicine today, and this piece can often feel difficult because of time constraints, and I think it is so worthwhile. It can really make the difference between success and failure to understand a little bit about your patient, and I'll kind of talk more about the specific things I think are important to know about your patient and their life. And then know your strategies, okay, right? Know the different technical approaches to starting buprenorphine. Then really know your adjuncts well, because these are, again, in the setting of fentanyl withdrawal, these adjunctive comfort medications have become so important and really also can help a patient to succeed and really make the difference. And then know your other resources in addition to medication that are available. And they're more important than you might think. Okay, so overview here of the options for starting buprenorphine. And this is will be review for some of you, and some of it may be new, or bits of it may be new. So there's our standard approach that, again, anybody who did a waiver training learned. And I think in the era of fentanyl, we're seeing that there are sort of two ways to use this standard approach. So just to recap, a standard induction would be waiting a period of time while the patient is in mild to moderate withdrawal, so that enough of the full agonist, in this case fentanyl, comes off of the mu receptors so that buprenorphine can latch onto the mu receptors and make the patient feel better and not worse. So in our waiver training, we were all taught to use COWS, the COWS scale, to assess when the patient got into enough withdrawal. And what we're seeing in the era of fentanyl, because it is easier to precipitate withdrawal, that I think a lot of places are just using a time cutoff. So we don't induct the patient until 48 hours out or 72 hours out. Or I just talked to a colleague in California who said, I don't induct anybody for 96 hours, and I haven't precipitated anybody yet at 96 hours. That's a really long time for a patient to be in withdrawal. But the standard approach can either still use COWS, you set a COWS threshold, or you can just set a time and say we're starting after we get to this time cutoff. Then a low dose induction, which many of you probably know as a microdose induction, is, and I'm going to go through each of these in detail, is where you're sort of sneaking little bits of buprenorphine onto the receptors while you're continuing the full agonist until you get up to a maintenance dose, and then you stop the full agonist. And then a high dose is simply starting with a really high dose instead of these lower 4 milligram induction doses. And then I'm going to talk about a combination of the two strategies that we use here at Fora. So let's dive into each one of these in detail. Again, this is some basics and a little bit of new stuff. All right, so standard, and a standard induction can be done either at home or withdrawal management settings. Use this approach all over. And again, you're going to reach a COWS threshold. We use a threshold of 16 here at Fora for fentanyl withdrawal. That's not based on anything. That just seems to work pretty well. We also make sure that the patient has at least 2 to 3 objective withdrawal symptoms as well. So we don't use just a number. We use the number plus the objective signs. Or some settings prefer to just set a 48-hour cutoff or 36-hour cutoff. Then you give an initial induction dose. We never use less than 8 milligrams here at Fora, and I'll explain why in a little bit. And then we go up from there, and we go up by 8 every 20 minutes to a maximum of 32 or even 40. We sometimes go up to 40 here for people with really high use patterns. So the advantages of this approach, it's familiar, right? I mean, everyone has been doing this for a long time. It's familiar to patients. It's pretty easy if you're using the hours approach. You know, we're just going to start at 48 hours or 72 hours. That's simple. If someone's doing this at home, you don't have to cut tabs or films. You can just go ahead, use the 8 milligram doses. You only need that one size dose. The disadvantages are this takes a few days in most cases, and it's just really hard for patients to be in withdrawal for that long. It's still possible to precipitate withdrawal, and if you're using this method and the person's been in withdrawal for some time, it's kind of easy to give up at that point. If someone goes into precipitated withdrawal and they're feeling worse, it's really easy if they're in a withdrawal management setting to just say, you know what, I'm leaving, like I'm over this, or if they're at home to just, you know, return to use. Low dose induction. This is an approach. Again, this is kind of what everybody knows as the microdose approach. And it is based on getting small doses of buprenorphine onto the mu receptors while the patient continues to use the full agonist. So if this is done in a home setting, the patient's continuing to use illicit fentanyl. This is not a comfortable approach for some people in the home setting. In a hospital setting, this is really a really helpful approach because the person can continue a prescribed full agonist to treat withdrawal, such as methadone or oxycodone, while the microdose is titrating up. And I think Emily is going to speak to this a little bit more at the end, so I'm not going to linger on this. This approach is possible to use for fentanyl withdrawal in the home setting. There are some challenges, but essentially it's, and there are many possible schedules for a microdose induction. It can be, you know, as short as a few days or as long as a couple of weeks. So this is just kind of one option that I threw up here, and I'm happy to answer questions about other schedule options. So again, you're starting with little bits, you're titrating up while the person is continuing to use fentanyl, and then you're stopping fentanyl use and then taking 24 milligrams and going up from there. So advantages, I think for a lot of patients, this is less scary. It kind of allows them to ease into things. And that's really appealing. It reduces that fear factor. And theoretically, there's a lower chance of precipitating withdrawal. And I think that there's some controversy around that and how this is going in various home settings. The disadvantages, it's pretty complicated, this method. It's a lot for many people to track. It also does require 2 different dose tablets, right? So you have to have the 2 milligram tablets realistically to be able to give 0.5 milligram doses or 1 milligram doses. And then you have to have the 8 milligram doses as you get up higher. And I know anecdotally of at least a couple of cases where patients took the, you know, I mean, when you're feeling terrible and if you're by yourself, it's pretty easy to get any tablets confused. So it is possible to take the 8 milligram tabs when you meant to take the 2s, and that can go south pretty quickly. It also takes, you know, relatively speaking, a pretty long time. And I think the longer transition times take, often the more time there is for things to not work out well. And then anecdotally, I have heard from, you know, a number of different sources and have seen this myself that patients during the up titration can start to have some withdrawal symptoms when they hit 2 milligram doses, between 2 and 4 milligram doses. So quite a few disadvantages, I think, of microdose induction off of fentanyl. Then there's the high dose approach. This can be used either at home or in a withdrawal management monitored setting. And this approach was really pioneered by our colleagues in emergency room settings. And the general approach was to wait at least 12 hours after last use of fentanyl. Hit a COWS threshold of about 16, again, with at least 2 objective signs of opiate withdrawal. So you're going to be looking again for, I mean, these are kind of my faves here because they're so easy to assess. And then you're going to give 16 milligrams of buprenorphine. Some places start with 8. We start with 16 here. And then again, go up by 8 to 32 milligrams. What are the advantages of this? Well, this is a pretty rapid transition, right? Also, only one size tablet is needed, and it's overall, it's a pretty simple process. It's clear, it's easy to follow. The difficulties in a, particularly in a home setting, in an outpatient setting, it can be difficult for patients to self-assess their readiness. And then with a high dose approach, if precipitated withdrawal occurs, it's likely to be pretty severe and hard to get out of, particularly in a home setting. We use an approach at Fora that we've developed over the last 2 years that's kind of a combination of low dose induction, some of the principles of low dose induction with a high dose approach on the second day. So because we are a inpatient setting, we have to stop all use of fentanyl once the patient admits, and we're not yet able to prescribe full agonists like one can do in the hospital. So for the first 24 hours, the patient is not using fentanyl. They are getting small doses. So we use 1 milligram doses at every med pass, which is about every 4 to 6 hours for about 24 hours, 20 to 24 hours. So they're getting about 4 milligrams total sublingual. They're also getting a lot of sedating adjuncts. I'll talk about the adjuncts in a minute. And then 24 hours later, they are getting either 16 or 24 milligrams of buprenorphine, and then again going up by 8 milligrams. So this is an approach that's really easy to use in a withdrawal management setting, in an inpatient setting. It's also really possible to set it up in a home setting for the right person with the right support. I'll talk about what that could look like. The advantages, again, this is relatively rapid. You can get somebody onto a maintenance dose of bup in 24 hours. And one thing that has been a real game changer for us is that, again, this, people come in, and most of our patients have used very, very recently when they come in to admit, and they're they're afraid about precipitated withdrawal, and they're afraid about taking sublingual bup. And we find that once they start with these low doses and they're going fine, it really, really reduces that fear around taking the larger dose. We also think, and and I can provide some references on this. This is a theory. Emily may be able to speak more to it, that there may be some process of, in that 24 hours of low dose bup, some resensitization and upregulation of the mu receptors that may in fact lead to a better response when people get that high dose on the morning of day 2. Anecdotally, I think we definitely see this. Those are the advantages. The disadvantages in a home setting would be that this does require the 2 different size tabs, and it does require tracking the number of doses and the time, and so it would have some of the disadvantages that a microdose induction, a low dose induction would have in the home setting. Again, in an inpatient withdrawal management setting, this is actually very easy to manage and really, really easy for the nurses. Then I also thought it was really important to include the quick start method, which can be done at home. I don't have experience with this personally, but I have eagerly talked to patients and colleagues who do have experience with it. And I think for the right patient, it's pretty terrific. It can be pretty terrific. And so this is a method of starting buprenorphine where a patient self-administers intranasal naloxone, and then immediately upon feeling withdrawal symptoms, they go ahead and they take 24 milligrams of buprenorphine, and they go up from there. And they can take additional adjuncts as well to prepare. So advantages of this, I mean, the obvious one is that this is an incredibly rapid transition, right? It's the entire process can be completed in under an hour, closer to half an hour, really. So they can get onto maintenance bup immediately. I think the disadvantages are also obvious. For a really short time, the patient feels really miserable. So this method is for someone who is able to manage really high distress for a short period of time. So again, it's going to be really important to know your patient when recommending a method. So how do we choose? How do you think through all these options? And it is really important because there isn't a one size fits all approach the way they're kind of used to be for heroin withdrawal. So again, can't say it enough, get to know your patient. And the things I really think about when I'm talking through options with patients are, what are their past experiences? Okay, are they someone who this is their first go around with buprenorphine, and they've never taken it before? They don't know anything about what the experience is going to be like, or is this someone who has made the transition to buprenorphine multiple times? And importantly, have they made the transition from fentanyl, or have they made the transition from heroin? Because those are 2 different experiences, or can be, as we know. And then really looking at if they have had experiences before, what's gone well, what do they know works for them? Because let's use that, right? Do they know specific meds really help? Awesome. And what has not gone well? Knowing that really helps you set up this experience for success. Then really looking at what's their current life situation. What is their home situation? Do they have a safe place to do this and a reasonable place to do this? And for some patients, a car can be a reasonable place to do this. If that's their safe space, they're comfortable, they have what they need, this can happen in a car. For other patients who have a house, who have a lot of resources, the house is not a good place to do this, right? Because they have little kids, or they have, there are particular reasons why perhaps their house is not a supportive place. And then also, what are their goals? What's most important? Is it most important to get this over quickly so they can go back to work? Is it most important to do it with the least amount of discomfort? In addition to getting onto the medication, what are the things that really, really matter to them? Is it important that they just be asleep through the whole process? So it's these kinds of granular questions that I think can really make the difference between things not going well and things going really well. I think it's really helpful to have a mental checklist. And I think if this is something that you haven't done a lot of, actually having a paper checklist, or one a template, sort of a visit note that really checks off these questions to ask. So I'd be interested in hearing if anybody sort of has any checklists that they go through, and if there are other questions that they ask. Okay. I kind of went through this, or some of it, a safe place to be, previous experiences. What are their support resources? Particularly, is there another person who is able kind of to be present with them through the process and give them meds, give them water and food? Because your options certainly for home induction really depend on whether someone's really on their own doing this, or whether they've got somebody who can really be managing the situation, and they can just be kind of in their discomfort or asleep, or not having to kind of track what's going on. And then do they have a trusting relationship with, and I put provider in the slide, it doesn't have to be the provider at all, but is someone in your setting, whether it's, a CMA or a peer. I mean, a peer is often the best. But is there somebody in your office or in your clinic that is really, has good connection and really good communication with this person? And then the patient's distress tolerance, and this is, I've really learned that this is such an important piece to understand about your patient, and it does take a little bit of time to dig and understand, but understanding again their motivations for doing this, and how much they can tolerate discomfort, and what kind of discomfort is hard to tolerate. If there's something that they just say, like, I can't stand whatever that is. Sometimes for some people it's I can't go to sleep, and that's just impossible. For other people it's like, if I have, if my back hurts, that's impossible. So knowing those things is so important. Then, of course, assess any medical considerations, comorbidities. Is this patient going to be withdrawing from other substances as well? That's a really important piece of the total picture to understand. And what other medical conditions do they have? The ones that I think about in particular are, severe hypertension, or hypertension that's really untreated. COPD, severe COPD, compromised, any sort of compromised respiratory picture, cardiac abnormalities, severe psychiatric conditions, and then severe chronic pain. Those are all kind of on my radar in terms of thinking about the setting that it's reasonable to do this in. Then, of course, assessing the patient's use pattern. Amanda talked about blues. Again, we know that blues are not one thing. They're, who knows what they are. They're all kinds of different things. But just getting a gestalt, is your patient using 2 a day, or are they using 50 a day? And then fentanyl powder, are they using fentanyl powder at all? Is it daily, or is it, once a week? Those things are really important to know. And then I have realized this is very important. Is there any IV use of powder? In my mind, IV use of fentanyl powder really puts patients into another category of severity in terms of what their withdrawal picture is likely to look like. And then how frequently, are you going to be trying to manage withdrawal for somebody who is coming off of regular IV use of fentanyl powder is really important to know. And we assume here that if somebody says that they're using heroin, because people still do come in and say I'm using heroin, I assume, and this is borne out by the clinical picture of withdrawal that I see here, that heroin is almost always now at least partially fentanyl powder. And patients will say to me that they know that as well. They assume that it is as well, and they can feel it. So reasons to consider referring your patient for an inpatient withdrawal management, I think would be concurrent regular use of alcohol or benzodiazepines. So if that's going to be part of the picture, the withdrawal picture, that is probably a reason for them not to do this at home. Also a history of really severe precipitated withdrawal with severe anxiety about the process. Some patients we have seen develop almost like a PTSD picture from having severe precipitated withdrawal that can make the transition just really difficult to do in a home setting. It's not impossible. So if that's your only option, do it. And there are ways that you can help patients get through it. But if an inpatient setting is an option in your area, it might be a good idea to think about it. Also, if somebody, again, is completely unhoused and doesn't have a appropriate housing situation to do this, try to seek a referral. And then severe comorbidities, including really anything that is triggered by severe stress, might make me think about trying to do this in an inpatient setting. And then I mentioned the other two, just overall really, really low distress tolerance or very, very high use patterns. To optimize outpatient success and, to optimize success, period, in whatever setting you're doing this in. Switching from IV use to smoking at least 1 week prior, if a patient can do it, I think that will really help. Again, there's no data on this, but anecdotally, transitioning from use by smoking goes better. Also, if they can taper over a week or two, we have a lot of patients that come into our inpatient setting and they know that they're going to come in and they've done a little bit of a self taper. If they're using over 30 blues, again, this is a complete gestalt, but 30 is kind of a cutoff in my head in terms of transitioning over 30. I think of as a very, very high use pattern. Where we often see a worse withdrawal. So if people can kind of get down under that threshold, great. That's going to make things go easier. Also, sleeping helps, and well, it is a little confusing now as I read it. Sleeping helps the withdrawal process, right? So one strategy that many of our patients use, and it is a really successful strategy, is they stay up for as long as they can before they come in. And that is really awesome because if they can get into a bed and just crash, they can sleep through more of this process. And that's something that somebody can do in the home setting as well. And it really helps. So as long as somebody has kind of a support person that can help manage the process, I would really encourage just going into this transition as tired as possible. Okay, so if you decide you're going to do this at home, terrific. Again, proceeding with confidence is going to really, really help your patient. So to have that game plan and then proceed with confidence. So once you've decided on the method that you're going to use, and you've talked that through with your patient, the next thing to do is really focus down on comfort medications. And a really important question to answer is it possible for the patient to take them on a schedule, or are they going to take them as needed? Then to talk through what are the things, again, that the patient's most scared of if they've done this before, what have been the biggest problems? If they've used any medications before that have worked well, it's important to note those. And then to think about what you're comfortable prescribing in the outpatient setting. I put in a pretty comprehensive list here. This slide and the next slide is a list compiled from what we use here at Fora, also what other institutions use. I'll go through it just quickly here and you'll have it. And the dosing is variable. I put in some kind of common dosage ranges. For muscle spasms, we love tizanidine. I know Hooper has had tremendous success with methocarbamol. We use them both here. Again, some patients will really have a preference for one or the other, and I would go with what they have a preference for. Loperamide, obviously, workhorse for diarrhea. For nausea, Zofran, I would say in the setting of severe vomiting, which we see is interesting. Just a little side note, for about a year, when people were almost exclusively smoking blues and had stopped injecting, we saw vomiting with withdrawal almost disappear entirely. We just didn't see it. And we had been, constantly managing vomiting with heroin withdrawal. Then with the advent of people injecting fentanyl powder, it came back again. And it came back, I have to say, with a vengeance. The vomiting off of IV fentanyl withdrawal is very severe. It's like projectile vomiting. And in my experience, 4 milligrams of Zofran doesn't do anything, like zero. So if you've got a patient with severe vomiting from fentanyl withdrawal, I would use 8 milligrams of Zofran exclusively. We find here that we have to use promethazine in those patients. We had really pulled back from promethazine in our setting because of its potential for oversedation. And we find with fentanyl withdrawal that we have to give a lot of other sedating adjuncts. So, so we're really careful with promethazine, and with IV fentanyl withdrawal, we do have to use it. Then for anxiety, the beast of anxiety, clonidine is really our workhorse here. We use it a lot. It's super successful. We use a lot of Benadryl as well, and we use hydroxyzine. There's anecdotally with people withdrawing from fentanyl, we actually find that they do better with Benadryl than hydroxyzine. And there's some, I'm not going to go into the physiology of that. Emily may be able to speak to it, but it has to do with the D2 receptors, and but both will work. Benadryl in the outpatient setting is available over the counter, so for some folks might be a better option. For stomach cramps, these are the old workhorses. And then for restlessness and agitation, which again, this is just the hallmark in my experience of fentanyl withdrawal as opposed to other opiate withdrawal. We have a lot of success here with gabapentin, and we go up to pretty high doses in those first 2 days of withdrawal. We also have used Zyprexa with some success, and that's something that I think people feel pretty comfortable prescribing in the outpatient setting. So I think it could be a really effective alternative if you can't prescribe gabapentin. For pain, Tylenol and ibuprofen at high doses can really help, I find, with the body aches. At the beginning, I thought, oh, these, this is not going to help. They actually really do. And then for sleep, we use a lot of trazodone, we use Seroquel and mirtazapine. I think any of these interchangeably can be terrific for sleep, whatever you feel comfortable prescribing. And if your patient has a preference, I would say use it. We have really found that scheduling adjuncts is just so important. And so if you're doing this at home and you have a support person, running through the schedule with a support person is really ideal. And then you just kind of roll those adjuncts out rather than chasing symptoms. It really makes all the difference in the world. If a patient is going to do this themselves, and they can get a pill box and you feel like they can do some self-administration on a schedule, great, give it a try. Write it down, use a paper template. I'm interested in if anyone has ever used a paper template that they've developed themselves or found or had experience writing out schedules for these things. I have a paper template that I'm happy to share if people feel like that would be a helpful resource. I can definitely get that to Stacie. Okay. Again, I can't say it enough. Getting ahead of withdrawal symptoms is so much easier than catching up when the patient is already in this cycle of feeling terrible and feeling terrified. Again, visual instructions. And again, sometimes it's nice to let the patient take the lead. Like some people just really do better if they can write down their own notes, whether it's on their phone or whatever works for them. And other people really need a little more guidance and something handed to them. You can use the SOWs. That's kind of it. I haven't heard of anybody using the SOWs, the home assessment, but it's still out there. You can print that out and use it. Again, really helpful to write down an adjunct list for the patient. And this sounds like, how could this be helpful? But it actually really is. Having the patient think about what are the affirmations, what my colleague Ayo Enrique uses this so successfully and so beautifully with patients. So have them think about, like, you know, is there a quote? Is there something that is inspiring to them? Is there something that they want to tell themselves if they're feeling really terrible? Have them write that down or print it out so that it's available and they can come back to it if they're feeling miserable or if they're feeling scared. So tips, again, most of my slides have focused on the outpatient setting, but some tips for withdrawal management settings, really build a structured container around the experience. That's what we've done here, and it's been so helpful for the nursing staff to have scheduled adjuncts, to have things done on a scheduled basis so that they don't have to be catching up, so that they don't have to be assessing, well, what PRNs now, just picking them, building the container, and going from there, so that, you know, we know most of our patients are on this low-high protocol. We know that at 6 a.m. they're getting their high-dose induction. So then the day nurses know, okay, by 11 a.m., if there are folks that are doing worse, you know, I know by late morning to watch for that, and then I know I'm prepared with how to manage it. So whatever, there's all kinds of different containers you could build, different adjuncts you could use. This can be tailored for your setting, but as much as you can, build that container. The next point, I can't emphasize this enough, at that first sign of restlessness in your patient, just leap on it. I call it the telltale toe. I don't know if there are any Edgar Allan Poe fans out there, but there's that great short story, The Telltale Heart. Well, we look for the toe twitch, and that's the patient who may be asleep, they're in bed, but that toe is kind of wiggling around, their foot's wiggling around. That's a bad sign. You want to pay attention to that patient and get some adjuncts on board or some more bupe. And then just have a plan that, you know, some patients are going to have precipitated withdrawal. It's going to happen, and just know how you're going to manage it. We have a lot of success here at Fora with IM lorazepam. There's research, and I can share that IM, people just do better with IM, and it's really not, I think, because of the pharmacokinetics necessarily. They're very similar to PO lorazepam, but that process of getting a shot is really helpful to some people, and it kind of works wonders for people that are in precipitated withdrawal. If I could say one thing that I've learned in this process, it's that 4 milligram doses of bupe in the setting of fentanyl withdrawal are like the road to ruin. Don't use them because they're large enough to precipitate. And just, I mean, we did use them for a long time as we were figuring this out. And so what we learned is that they're large enough to really precipitate some heavy duty withdrawal, even many hours out, and you get yourself into a big hole. And then it is really hard to get out of that hole. You can give 4 milligram doses until the cows come home, and they don't seem to do anything. So yeah, stay away. Okay, this is a super busy slide, but I wanted to make sure I included everything because, and I think, you know, at first pass, you might look at this and think like, oh my God, really? Like, do these things make any difference? Well, you know, I would say these can make all the difference. And this is a list that our nurses have we've sort of come up with this collectively. We find, so I'll just kind of go through them. We find that aggressive hydration it really helps. Many of our patients come in pretty dehydrated, and during the withdrawal picture, they have a lot of sedating meds, they're asleep, and they don't drink fluids. And when they do start to drink fluids, it's amazing how much better they feel in their bodies. And, you know, again, if you're doing this at home, it's kind of like labor. Have your patient prep. Like, what do they like? What are they going to drink when they're feeling miserable? Have that at the bedside or in the fridge. Have it ready. This is another thing that can seem like, oh, how could this make a difference? But it does. Make sure you've got straws. Make it easy for people to drink. Massage, and it's really so. This severe internal restlessness that we see with fentanyl withdrawal responds to movement on the outside of the skin. So it can be anything from, like, you know, rubbing, like you would rub someone's back and forth, to kind of tapping or patting, like you would see in like an EMDR type technique. Kind of doesn't matter what it is. And again, many patients have preferences of just what feels better, but movement on the skin helps calm that movement on the inside. And it's really quite dramatic, the effect. Our nurses discovered that that Vicks, Icy Hot, Tiger Balm, any of those kind of mentholy eucalyptus type balms also are really, really helpful. Hot water bottle is one of our mainstays here. Fans are something that patients asked for. I think this is something that people are using at home, and they're really helpful. We set up fans and the patient wants them. I didn't put this in, but I'll say it because I'm remembering it just now. We put patients on the floor. We take our mattresses off the bed and put them on the floor for some patients who are super restless and just moving all over the bed and in danger of falling out of bed. And we've also had patients just ask for that, or ask, you know, they're feeling better and we want to move them back up into the bed, and they say, no, like, can I please stay on the floor? Like, it just feels good. I feel safe down on the floor. Also can't say enough about showers and baths. Those particularly once you're kind of a day into this, the shower, somebody can be feeling miserable. They get into the shower, they come out and they're like, oh, I'm better. I'm through this. Walking, stretching. Again, if you're doing this at home, you know, there's really opportunities that we don't have in the inpatient setting to go outside, walk, stretch, you know, don't lie in bed feeling miserable. Many patients don't feel like getting out of bed, but again, when they do, they feel better. Essential oils, this is something one of our nurses started doing. So we have a box of essential oils in the back now. Don't put them directly onto skin, put them in another oil or put them on a cotton ball, but this also can help patients just kind of come out of this miserable experience and connect with something outside of their own bodies. Weighted blankets. Gosh, I wish we had funds to buy weighted blankets for every bed that we have. Bundling people up, kind of like the burrito wrap, I call it, like you do with a distressed baby. Yeah, helps helps big people too when they're feeling restless. We have acupuncture here a few days a week. The Lotta protocol, which you can learn about online. It's an acupuncture protocol in the ear that can be done with ear seeds. So if your patients have any access to acupuncture and can go get this done before they start the withdrawal, the ear seeds are little kind of tiny little, they're not seeds, but they're tiny little pellets that can stay taped into the ear, and they can press on these points while they're at home in withdrawal. That can be terrific. Also, having a really soft space and surroundings when people are really, really restless. Again, it just helps to kind of, if they're doing this at home, have their space set up on the floor or a couch where they can just kind of roll around, not hurt themselves, and move as they need to move. Music. Often patients, not often, sometimes, and I always love it when they do, patients will come in and they'll say, can I play my favorite song before I go into the back? And I've just thought, gosh, I wish we could have everybody have their personal soundtrack. And if someone's doing this at home, they can. So have them tee that up, you know, what music do they love? And then having another human there or a pet can also make all the difference. Again, this human contact, can't say enough about how important it is. How am I doing on time? Just, I mean, I can see what time it is, but how much time do I have left?
You're doing great, Jenny. Just a few more minutes and we can ask some questions.
Looking
Okay.
good.
Okay, great. Okay, again, to sort of piggyback on what Amanda already said, do consider, if you're doing this at home, to prescribing buprenorphine mono product for these starts. Again, this is kind of the standard of care in inpatient settings. And we do know that intolerance to naloxone exists. Again, I won't repeat what Amanda said. It may be much more common than we know. And the most common ones that we see here in both our outpatient and also our residential setting, which is, we have a residential setting as well, so we can see these effects pretty clearly. And so we do see nausea, vomiting, and headache. And when starting, since we're starting patients on these much higher doses of buprenorphine, the symptoms are likely to be more severe. And then if you're not comfortable continuing to prescribe buprenorphine, just prescribe it for a few days to get through the transition, and then you can switch to Suboxone at follow-up. That's what we do here. We start everybody on mono product, and then we give them a bottle of Suboxone when they leave, unless there's a reason, unless they already know they have an intolerance. Also, can't say enough about this. It's a super simple thing. It seems like nothing, and it can really make a big difference. Really review with patients how to take buprenorphine. I think this is something, again, that was kind of part of the waiver training, but it's easy to kind of, not emphasize it. But when you're in the induction process and you need to get buprenorphine onto the receptors, you've got to take it correctly. So moist mouth, right? Nothing acidic before or after taking your medication. This is super important. Take the medication while sitting up. It is really impossible to take this medication well while you're lying in a bed. And if you're feeling miserable, you want to lie down. It is really worth sitting up and taking it. And then just reminding patients, make sure this dissolves fully. Make sure you hold the saliva for several minutes. And then reminding them it's okay to spit out the saliva. Some people just really, really, really hate the taste of bupe. Spit out the saliva. Once it's swallowed, they're not going to absorb anything. There are still many patients I find that have never been given this really good education, and it does make a lot of difference. A colleague on one of the ORSAM forums has really emphasized this technique of tucking the chin. I do actually find that it helps. So if you do it yourself and you sit there for a couple of minutes, you realize that if you tuck your chin, it kind of pools the saliva and it makes it, you can't really swallow too well while you're tucking your chin. So it really does mean that you're going to, I think, absorb more. So I think that's a great thing to emphasize. Crushing the tabs can help. Again, some people, crushing can be triggering for some patients. So this is something I would just think through and talk to your patient before recommending. However, some of those 8 milligram tablets are gigantic and take a long time to dissolve. So if a patient is okay with crushing, you can buy a home pill crusher for $3 at the pharmacy. That can really help. If precipitated withdrawal happens, it's going to happen. We know it's going to happen, so be prepared. As we all know, there's two strategies. You push through it with more bupe and more adjuncts, or you take a break, you treat the symptoms with adjuncts, and you kind of start again. Talk these through with your patient ahead of time if you're going to do this at home, and decide what the approach is going to be. Deciding in the moment is not a great idea. And it's also just okay, and I can't say this enough, like, let the patient know whatever happens, it is okay. There's a plan B, they can try this again. Consider prescribing a benzo. This is controversial. I'm happy to connect with people after the presentation about this. It is unbelievably effective in precipitated withdrawal. Expert tip, we do this at Fora. I started doing this after ASAM last year. There was a presentation by the California Bridge folks. If people don't know about California Bridge, I'm happy to share that resource as well. But one of their ED docs said effective way to manage precipitated withdrawal is 2 milligrams of lorazepam at the same time as 16 milligrams of buprenorphine. We find it incredibly effective here. So effective that we now give all of our induction doses together. So we give our induction doses of 16 milligrams of bupe together with that 2 milligrams of lorazepam. Additional, really kind of the workhorses for precipitated withdrawal. If nausea, 8 milligrams of Zofran. Again, don't even try 4. If people are restless, those higher doses of gabapentin. I think if you're relying on gabapentin only and you don't have a benzo on board, I would even go higher, maybe do 900 milligrams or 600, and then 600 an hour later. If somebody's anxious, 5 milligrams of Zyprexa or clonidine, either of those are super helpful. Benadryl too, 50 of Benadryl. And again, the severe back pain, if that starts to hit, I would just go ahead and maximize your NSAIDs right away. If you are not comfortable prescribing a benzodiazepine or, higher doses of any sedating adjuncts, one option is to consider an office-based start for folks, particularly folks who have, if you're in a rural area and you don't have access to inpatient withdrawal management and you have someone who has a higher use picture, people are doing this. And I think we forget that, not that long ago, Bup was started in the office all the time. And then we realized, oh, this is actually easy to do at home. But office-based starts can be a great kind of hybrid option. So you kind of make the plan, you send prescriptions home, patients pick up the prescriptions, they can start the low dose at home for a couple of days, get things rolling, get some Bup in the system, then they stop using and they come into the office, and you can do that high dose plus adjuncts. And some people feel more comfortable giving the benzo in the office setting and observing for a couple of hours. So just wrapping it up here, medical follow-up. Really prepare your patient for an adjustment period of possibly several days or even up to a week or longer of just kind of feeling once they've gone through this transition. And for most patients, this does resolve, but there is a transitional period. Not for everybody, but it's good to be prepared. Again, can't say enough, encourage rest. Like, don't plan to go back to work like the following day. I have patients that come in and say, I'm going to do this, I'm going to go back to work, operating a forklift. And I no, give yourself a day at least to recover and take care of yourself. And then again, plan for at least 32 milligrams. If they don't need it, they don't, but it's good to plan. Always have a plan B, and always let the patient know that there's a plan B. And then the social follow-up, so important. Let the patient know that they can call someone in the office, or even better, have somebody call to check in within a day or two, just see how things are going. Peer support, oh my gosh, if you have access to a peer, that is always the best possible option. But any human being would be terrific. And then here we go. I can't say enough about this. Just never, never, never underestimate your own superpower. Whatever you do, whatever part you have in this process, your attention, your understanding, your empathy, and just truly your love. We don't get to talk a lot about love in medicine, and I think we need to. So whatever if you're not comfortable with the word love, you can call it something else, but truly just attention. It makes all the difference. Someone knowing that you care about this process, you care about them, and that you are going to be there for them through the process can make the difference between not succeeding and succeeding. Any questions?
Spectacular. Thank you so much. That was absolutely, absolutely amazing. So folks, real quick, here's what we're going to do. Rather than bracket out a chance right now to do questions, I want to make sure we keep on time and get our third presenter a chance to deliver all of their content. And just a reminder to everybody as well, we're going to be sharing all of these resources with you after the event today. So I'll be sending out an email to everyone who's registered that has all the slides, additional resources, and it gives you a chance to follow up as well. So hang in there for that towards the end of this segment. And we'll do the full Q&A after our next presenter's session.